Thanks for joining this talk. My name is Rebecca Smith-Bindman, and the title for this talk is Radiation from Medical Imaging, a Hidden Epidemic. So the outline of my talk today is, first, I want to tell you what I will be talking about and what I won't be talking about, the focus of my talk. Next, I want to give you a little bit of background about why CT scanning has been in the news so prominently since 2009. Next, I want to go through some of the data about what's known about the carcinogenesis of radiation, because I think it's something that many people know very little about, but I think it's worth reviewing the literature, at least at an overview level. I want to then give you some insights about CT radiation exposure in the U.S., meaning how much imaging we're using and what the population's exposure to radiation is. And last, my belief on what needs to happen to improve the safety of medical imaging and reduce exposures. First, just to state the obvious, everything we do in medicine involves trade-offs, whether we're talking about a physical exam, a diagnostic test, a treatment. Everything involves risks and benefits, and we discuss those risks and benefits for many things that we do in medicine. No one starts a new drug without being instructed that there are some potential harms to this drug. The purpose of my talk today is not in any way to talk about all of the risks and all the benefits of CT imaging. That's too vast of a topic to really cover. The purpose of my talk is to focus on a single known harm of medical imaging, and that's radiation exposure, and to improve your understanding of this risk so that it can inform your practice, be it how you do the exams, how you order the exams, how you oversee the exams in your facility. In terms of what one would have to cover for the risks and benefits of CT, as a snapshot, it's an enormous topic. I think many in this audience and many in the country would believe that CT scanning has really transformed medical imaging, and most importantly, it has led to the earlier and more accurate diagnosis of diseases and has led to improvement in patient outcomes. Outcomes meaning patients' health is improved because of the use of CT. We haven't done a very good job, I would say, of quantifying those benefits, but we know there are benefits, and there have been some studies. In terms of the risk, there are a large number of risks. There are false positives. False positives mean the exam finds something that's not really a problem. But to know it's not a problem, often there's a lot of chasing and other testing, and there can be a whole downstream effect from a single CT scan that leads you to chase things that in the end actually were not important. Those are false positives. Overdiagnosis is a little more complicated. That's where you find disease. It is truly disease, unlike false positives, but the disease would never have hurt you. A good example of that is prostate cancer in elderly men. That's not to say prostate cancer is not a problem. It is a problem. But there's a huge reservoir of prostate cancer that never would have hurt men had we not found it through screening, and those overdiagnoses are widely considered a harm of screening. We don't talk about contrast reactions very much anymore, but we all know about small as well as rare, significant contrast reactions, which are harms of imaging. And the soaring cost is one potential harm that gets talked about a lot these days. That's driving our calls for comparative effectiveness research, but I'm not going to talk about any of those benefits and harms. I'm going to focus on the last bullet slide, which is radiation exposure. And radiation exposure, the doses are in the carcinogenic range, meaning they can cause cancer, and I want you to understand this potential risk more than many people currently understand it. So I wanted to give you a little insight into about why we're talking about radiation from CT so much in the last few years. This has become front page news across the country, and before 2009 really that wasn't the case. And I think there are three things that contributed to that. First were the reports of radiation overdosing, originally reported at Cedars-Sinai Hospital in LA, but extended to many more hospitals since then. These were patients who underwent brain perfusion scans, and these patients received radiation doses that were in error, that were 100-fold higher than a simple brain CT. Patients had acute radiation poisoning, they lost hair, they had mental status changes. This was really gross errors. People had a band-like distribution that made it onto the front page that really helped us see that when this very powerful machinery is used incorrectly, it can lead to harm. Unrelated to those accidents, and there have been since over 500 such patients who have been reported, there were a whole series of radiation accidents related to the treatment of patients who had cancer. Radiation oncology patients using CT scans. A New York Times Pulitzer Prize-winning reporter described several cases, really tragic cases, where patients had severe injury or died from these radiation overdoses. And while they were cancer patients, their deaths were caused from these accidents. And lastly, there are a number of published reports that described not just errors in how CT scanning is used routinely, but that the doses that are used every day are higher than needed, they are highly variable, and using modeling would be projected to lead to up to 30,000 future cancers related to the radiation exposure. So all of these things sort of together led to a growing awareness that these machines are powerful and that we may not completely have under control their safe utilization. So radiation, very simply, is energy. Radiation is high-speed particles or electromagnetic waves. Ionizing radiation is a subset of radiation. It's different than your cell phone radiation or your microwave radiation in that it has a lot of energy and is sufficient energy to break chemical bonds. I'm not attesting to the safety of other forms of radiation, but we know ionizing radiation can break chemical bonds and lead to harm. There are many sources of ionizing radiation, and these are all around us. They come from the sun, they come out of the earth. These cannot be eliminated, but to the degree that's possible, we've tried to minimize our exposures to ionizing radiation as a society because we know there's potential for causing harm. Most of what we know, not all, but most of what we know about the harmful effect of radiation comes from epidemiologic studies. These are studies where we study large number of patients and we look at their exposures and look at their risk of diseases. And that's mostly what we know about radiation, although there are many biological and basic science studies as well. I won't focus on those quite as much. Epidemiology is basically the foundation of public health. It's what leads us to understand how to improve public health. And in fact, in the area of epidemiology, there has been no carcinogen, that means cancer-causing agent, that has been studied as much as radiation. And this has been studies across diverse populations, including directly studying the radiation from computerized tomography. Radiation, as in the same range as computerized tomography, up to at 10 millisieverts or greater, are known to cause cancer in some individuals. And I want to go through some of these data to give you an understanding, a flavor for where these data come from. So the U.S. National Academies of Sciences put together a committee to study what's known about radiation, low-dose radiation, in the range that's used in medical imaging, and they compiled something called the Bear7 Report. And it's an extremely comprehensive report, and what they did as part of this report is very esteemed scientists from across an entire broad range of disciplines summarize everything that has been published until the year that this report came out on medical imaging, and helped quantify what we know about exposures and the likelihood of those exposures causing harm based on the age of the person who was exposed, the year of exposure, and they did extensive modeling of these data. And the report is quite long, it's quite detailed, and each of my slides summarizes hundreds of pages of this report. So one of the sources of data that they used in the Bear7 report were studies of the Japanese atomic bomb survivors. This group of individuals, about 120,000 survivors of the atomic bombs, have been studied extensively, and they've been as part of a group of individuals called the Lifespan Study. Individuals who were exposed to the atomic bombs received a wide range of exposures, ranging from very little to very high dose exposures. The median exposure, the middle dose that was received by survivors, is 40 millisieverts. And there are a lot of numbers we're going to talk about today. I want you to keep that number in your head, the median survivor. For individuals who are in this cohort, individuals who receive doses as low as 10 millisieverts are at increased risk of developing cancer, all solid cancers and leukemia. There have been really extensive modeling done on these data, and I will admit that there's some variation in individuals' belief on exactly what the risk is. But there is no disagreement that the risk among these survivors is increased, and substantially increased for all cancer. And these data provide a lot of information about what we know about the harmful effects of radiation. Entirely unrelated to this population, we know a lot about the harmful effects of radiation for individuals who've been radiated as part of their treatment for cancer. They've been radiated for malignant disease. The doses for these treatments tend to be higher than the doses we're talking about in medical imaging, but they give us a really good understanding about what the long-term effects are from being exposed to radiation, because about half of patients in the U.S. who have cancer end up getting radiation as part of that treatment. There have been a lot of studies of individuals in the U.S., and patients who get radiated for cancer end up being at marked increase of getting subsequent cancers. And no one's saying that that's not good to get treated for cancer, right? Most people would trade a future cancer in order to treat a current cancer. But it gives us an understanding. And for some cancers, for example, children who survive Hodgkin's disease are at markedly increased risk of dying of secondary cancers. Separate from this population, an entirely different population, are individuals who were radiated in the U.S. for benign disease. While we would never use radiation for these conditions now, we used a lot of radiation earlier last century for benign conditions like tinea capitis or benign breast mastitis. And individuals who received radiation in these contexts developed cancers in the area that they were treated: thyroid, salivary gland, central nervous system, skin, breast. And it gives us data to suggest that when you radiate patients, you get cancer. An entirely different population of patients. When I say population of patients, I mean hundreds of studies have been done on these populations. There have been a large number of studies of individuals who got repeated x-rays. For example, young girls who had scoliosis who would get extensive x-rays of their spine to evaluate the progression of their scoliosis. The doses, again, tended to be relatively high in these patients, in the order of grays, but all of these groups were more likely to develop cancer in the areas that they were radiated. There's recently been a publication of a study directly looking at medical radiation using computerized tomography. And while many studies have looked at radiation, this is first to look at it directly with CT. Dr. Pierce published these results, and we're very fortunate to have him at this conference, and you can hear his entire talk on this topic. But in summary, he was the first to directly study CT. Scientists followed approximately 175,000 patients in the UK who underwent CT scanning, and they compared children who underwent 2 scans, 3 scans, as compared to 1 scan. And what they found is relatively quickly, within 10 years of having undergone the CT scan, patients who received organ doses in the ballpark of 30 to 50 millisieverts or greater tripled their risk of brain cancer and leukemia, respectively. And what I find most important about this study is that the results were entirely consistent with what we know about radiation exposure from the Bear7 report. It's basically another source of radiation exposure that shows it leads to cancer. I think a repeat study in the U.S. is important for lots of reasons, but I think this provides very important information about what we knew even before the study, that radiation can be harmful. And lastly, there are a lot of papers that have looked at environmental causes of radiation and harm and cancer, and this too is a very broad literature. There have been studies of radiation workers who've shown, these studies have shown that exposures as low as 5 millisieverts, individuals exposed through work are at increased risk of dying of cancer. There have been many studies of radon, the source of ionizing radiation that comes out of the ground. In Canada, a recent study estimated that 16% of lung cancer deaths in Canada were the results of radon. And there have been recent studies out of looking at Chernobyl cleanup workers, and workers who used very low doses of radiation or exposed to low doses were at increased risk of leukemia. We're very fortunate at this conference to have Dr. Per Peterson, who will talk a little bit about, or sort of the more broad use of security measures within the nuclear power industry to ensure that we're safe, because I think it provides a model for how a systems-based approach can really help us. So in summary, there is substantial evidence about the radiation risk from medical imaging. Interestingly, the Institute of Medicine recently published a report on environmental causes of breast cancer, and they concluded that avoiding exposure to unnecessary medical imaging is the most important step that women can take to reduce their risk of breast cancer. And the chair of that report, we're fortunate, will also present at this meeting. You can hear in detail what they found. The radiation risks tend to be higher among children, although it's very interesting that while the risks go down, as patients get older, the risks go up as well. So there's a U-shaped distribution, which means among the oldest individuals, 50s, 60s, where exposure to imaging is greater, the risks are greater as well. And in the U.S., the radiation exposure to the entire population from all sources has increased over 50%, and that's a huge jump. And that increase is entirely due to the greater use of computerized tomography, which has increased 600-fold in the last 2 decades. In terms of where we get radiation from medical imaging, there are basically 2 ways we can get that radiation exposure. In nuclear medicine studies, a small amount of radioactive material is injected, swallowed, or inhaled by a patient, and then gamma rays that are then emitted by the patient are detected by screens, and the radiation is displayed on the computer. Nuclear medicine contributes about 25% of our medical radiation exposure. The rest of the radiation exposure comes from X-rays. And for X-rays, the X-rays are delivered by a device that comes from the device, goes across the patient, and then are collected on the other side after passing through the patient. And these X-rays are used by conventional X-rays like a chest X-ray, fluoroscopy, angiography, all kinds of interventional procedures, as well as computerized tomography. Although X-rays altogether are 75% of our exposure, CT is 70% of that. So most of the exposure is from CT. So I just want you to think about other sources of radiation and how CT compares with it. How much radiation is delivered by an abdominal CT scan? And I use abdominal CT scan as an example because that's the most common type of abdominal CT scan that we use. Is it the same as 300 round trips from California to Europe? Is it the equivalent to 900 chest X-rays, 1,800 dental X-rays, or 180,000 airport scans? And the answer is all of the above. So I, for one, used to avoid the airport screening device, and I no longer really think about the backscatter scanner as being terribly important when I put it into the context of CT scanning, where the risks are just so much greater. So what are the observed doses for CT scanning, and what are patients' cumulative exposures? If you all do a quick search on the internet for what the radiation exposure is of an abdominal CT scan, I think you'll get a number that's in the ballpark of 8 to 10 millisieverts. And I just want to show you what some of the data look like compared to what you would learn doing a quick search of very reputable sources. So I'm going to share with you results from 2 research studies. The first is a paper we published in 2009 that looked at the radiation doses from routine CT scans conducted at 4 hospitals in the San Francisco Bay Area. What was somewhat unique about this study is we grouped the patients by why they were sent for imaging, what the clinical question was, rather than grouping them by what the radiologist chose to do when they arrived. So if a patient was sent by their clinician to look for a pulmonary embolism, that's how we grouped them, rather than the kind of protocol the radiologist did at that time. And we found pretty dramatic variation in doses across patients and across hospitals. This first slide of results gives you a sense of the radiation dose for 6 groups of indications across the 4 sites. So if you look at the first line of data for routine head scan, at site 1, the average radiation dose, this is shown in millisieverts, was 3 millisieverts, the same at site 2 and 3, where at site 4, the average dose was 2. These numbers are close together, and it's a little hard to see within the numbers I've presented here, but there was 20-fold variation between patients who were sent for the routine head. If you look at suspected stroke patients, these are patients sent to look for a stroke, the average dose, the mean dose at site 3 was 8 millisieverts, where the average dose at site 4 was 29 millisieverts, more than 3 times higher. And the same thing for all of the indication we looked at. When we looked at suspected pulmonary embolism, while 3 sites had a dose about 8 or 9 millisieverts, 1 site had a dose that was 21, substantially higher. And if you look at these numbers numbers carefully in the paper, you learn very quickly that no site, no facility was doing a good job at having the lowest dose across all the indications. For every indication, there was a different site that had the higher dose. We looked at these data graphically, the same data, and each of these box plots is looking at the dose for a different indication. So on the left is a routine head CT, all the way to the right are looking at patients who had suspected cerebral aneurysms. The dark red line is the 10 millisievert threshold that we often tell patients is the dose for having an abdominal scan. The 3 to the end, 3 to the right, box plots are for abdominal scan, and you can see in that box plot, the box plot shows 50% of patients receive a dose in the box, and the whiskers show the highest and lowest 25% of doses. You can see very few patients receive doses that were around 10%. Nearly all the patients received doses that were much higher than that 10 millisieverts. Some patients received doses as high as 90 millisieverts for a single exam, and the dotted orange line is showing the median survivor data for the Hiroshima cohort. And I'm not saying that's necessarily the best comparison, but it just helps show that the doses we're talking about from these single CT exams were very high. Using Bear7 modeling, we estimated the risk of getting cancer from the scan, and the risk was as high as 1 in 80, almost 1 in 80 patients would get cancer from a single test. And this next slide shows that graphically. These dots, each of these lines is for a different type of study, and the dots reflect the doses received by an actual patient. And we ordered the patients by whether they got a low dose or the high dose. And if you look at the middle red line, that shows the dose received by the middle patient, the 50th percent patient. And if we look at the y-axis, that shows the lifetime attributable risk of cancer, how many cancers you might get if these doses were delivered to 1,000 20-year-old patients. And on average, you'd expect if you gave this type of CT scan to a 20-year-old patient who had the average dose, you would get 4 cancers in those 1,000 patients, which is a lot of cancers to get in 20-year-olds. And then if you look all the way to the right, the dose that was received by the highest dose patient, the risk of cancer was 1%, meaning if you were unlucky enough to get the highest dose in this, in our experience at these 4 hospitals, your risk of cancer would be profoundly higher. Something to notice in this is that the dotted lines reflect different studies, and the bottom line are brain CTs, which tend to have less of a gradient in dose and less of a gradient in risk compared to abdominal and chest CTs. I wanted to spend one slide about communication. We have Dr. Semelka speaking at this meeting about communication, and I think you'll find his talk very exciting, but I just wanted to raise the issue of communicating. What needs to be communicated if we're talking about a risk that can be high as 1%? I was honored to get to present at a U.S. congressional hearing on radiation safety in 2010. And one of the speakers was speaking about whether or not we should communicate risk. And what this speaker concluded is that it's really entirely the radiation, it's the radiologist's job to ensure safety. We don't want to frighten patients by talking about it, and that the risk of radiation injury from CT is virtually non-existent. And I believe these comments are no longer acceptable to patients. So there's a whole spectrum of what we might choose to communicate from patients. All the way on the left of the slide showing nothing, all the way on the right talking about specific organ absorbed doses, lifetime attributable cancer risk, adjusted for lots of variables. And I'm not saying exactly where on this communication spectrum we need to be, except that it's not acceptable to communicate nothing and to expect that patients will just accept this risk without having some understanding of where it comes from and how it needs to be balanced by the justification for studies. So I want to show you a second study. This is looking at patients' cumulative radiation exposure within a year's time among patients enrolled in one of a number of large HMOs. Overall, we had about 2 million patients per year, over 15 years of follow-up, and these results were presented last year. And we looked at the actual doses delivered in clinical practice, as well as cumulative exposure, since we know that patients who get imaged once are more likely to get imaged several times. So just to think about for a moment and pause, how many tests of CT do you think that we do every year? Do we do one test for 5? I'm calling them patients in the slide, but it's really 5 individuals. These are individuals who are members of an HMO. Is it 1 in 10 individuals, 1 in 100, 1 in 500, or 1 in 1,000? Think about that. How many tests do you think we do? And I will tell you that very few people guess correctly. So I'm showing you a graph here of 4 imaging tests, and these were published in the paper, looking at the different tests by population. On the y-axis is looking at how many tests, and on the x-axis, what year, and 2010 is the most recent year we looked at. I'm showing you here CT, MRI, nuclear medicine, and PET scanning. If we focus on CT scanning, you'll see in the most recent year that we included, 2010, it was just shy of 200 CT scans per 1,000 patients. And that's approximately the equivalent of 1 in 5 patients getting a CT scan every year. These are lots of individuals who are undergoing CT scan. The numbers have actually increased since then. We're up to about 90 million CT scans in the most recent year counted last year. So we're using CT scanning a lot. In terms of the doses, as part of this paper, we extracted the radiation doses that were used for CT scanning, and we collected doses for over 4,500 individuals. The examinations were chosen randomly, so we didn't pick examinations based on high dose, low dose, or a particular protocol, but rather picked them based on patient characteristics, selecting younger patients and older patients. And we collected the dose information from the DICOM headers and looking at the dose report, and we calculated the dose output and used mathematical phantoms for 6 different sizes to estimate organ doses and to calculate effective doses based on summing the different organ doses. And those doses, we looked at several different metrics, were highly variable using every metric we used. So as an example, for child abdominal CT scan for children ages 1 to 4, the dose for that scan ranged from 5 to 115 millisieverts. Really an extraordinary and unacceptable broad range in dose. In terms of cumulative exposures, the radiation among this population over the 15 years that we studied more than doubled, with the greatest increase in the number of patients who received very high doses, which makes sense if we're really doing a lot of repeat imaging in some individuals. By 2010, 16% of patients imaged had an annual dose greater than 20 millisieverts. And I'm not sure comparing doses to radiation workers is exactly the right comparison, but at least gives us some place to begin understanding, is this a small or a large dose? And 20 millisievert is the annual limit of radiation exposure in most of the world for radiation workers. Nearly 5% of individuals in our cohort had a dose in 1 year greater than 50 millisievert, and this is the annual allowable dose in the U.S. for workers. And again, just like in our earlier work, the doses per scan were high and highly variable. You will hear a lot about this study in other talks. Dr. Miglioretti will talk about the results of this study that are coming out separately in pediatrics, and I will talk about it a little bit more in another session. But the doses, again, were highly and unacceptably variable, and a very small amount of the variability had to do with patient needs, such as differences in size, and much more had to do with other factors that were not because of requirements of the patient. This graph is showing the annual exposure to radiation received by the highest exposed individuals. And by 2010, those who got the highest dose, the highest 1%, received over 100 millisieverts in a single year. And these are very high exposures. So what needs to happen to lower the exposures? The only way to lower the exposures for medical imaging is either to lower the number of tests that we're doing or to lower the dose per examination. I think both of these are important. Looking first at utilization, there are a lot of factors that have contributed to the increased use in CT scanning, and Dr. Brink will talk in the next keynote a little bit about the benefits of CT scanning and why you are using it so much. But clearly the most important factor is improvements in technology. CT scanning can now solve lots of questions it couldn't answer in the beginning of its time. We can now use so many more protocols that allow us to use it for a broader range of indications. But there are a lot of other factors that are driving the use of imaging that have really very little to do with whether or not it's helping patients. There's a huge increase in capacity. There's a lot of equipment out there owned by radiologists, owned by non-radiologists, and the increased availability of the equipment requires it to be used because it's so expensive. Until recently, there's been no disincentive from a patient's perspective to getting CT scanning. It's perceived as a fabulous new modality. It can make a diagnosis. It can provide reassurance. And that's been presented, I think, to patients as a one-sided benefit without understanding that there are also risks and harms. Physician demand has really grown, I think, at an unsustainable rate. It's often easier to order a scan than it is to see and talk to a patient, and that, I think, needs to stop. Part of the drive for physicians are concerned about malpractice. There's really a lot of defensive use of everything in medicine, and defensive use of medical imaging, I think, is one of the defensive uses that really drives why we're getting so many CT scans, particularly in emergency department settings. And lastly, it's highly profitable. And we hate to have this be a major driver, but nonetheless, it's a highly profitable part of medical imaging. And since there hasn't been much thought of disincentives, it's led to growth in imaging. I believe the single most important factor, however, that has led to so much imaging is the relatively lack of guidelines about when to image and how to image. There are a lot of guidelines out there, but many of them are very imperfect, are very flawed, and people don't follow them. Now, there are some acceptance to that where there are really outstanding evidence-based guidelines. We're going to hear about some of those in this symposium. Dr. Nathan Cooperman is in the forefront of developing some guidelines, and I think they're highly useful, but we need much more of that. The lack of evidence, uncertainty regarding appropriate use of imaging, and then a lot of the profitability results in overuse. And I think reducing inappropriate imaging really needs to be a shared responsibility, and it's in part why we've created this symposium to really allow a lot of different viewpoints to come together and think about how we can make strides in this area. I want to point out one effort that I think is very important, Image Wisely, which you will hear about as part of this symposium as well. This is American Board of Internal Medicine Foundation supported project to reduce unnecessary testing of all kinds. There have been a very large number of societies that have joined and contributed to this campaign, groups like the American College of Cardiology, the American College of Radiology, and so forth. Each of these organizations picked 5 areas where their members do too much testing, where there's overuse, where they really need to improve it. And what's fascinating is that every organization's 5 top most priority areas included reducing unnecessary imaging with CT for particular problems. Some societies had up to 3 areas where the major overtesting involved CT scanning. So I think there's growing awareness that we're using too much CT, and we need concrete strategies to help it become more appropriately used, more justified in the language of making sure that when we're giving radiation, there's a reason, a justification for its use. So that's the utilization piece. Separate is the radiation dose piece. Why are doses so variable? And I think that's an easier question to answer. There are simply no comprehensive standards or guidelines for how CT should be conducted, and the result, we have this variation. We have an overriding principle in radiology that doses should be as low as reasonably achievable, a very good guideline, but without there being specifics of what's reasonable or what's achievable, it's left for every facility, every physician, every physicist to redefine what a LARA means. And in the absence of explicit guidelines, which I think we need, there's tremendous practice variation that I think results in unnecessary harm from excessive radiation. No professional organization or government group is responsible for collecting and reporting radiation dose information, and technologists who conduct CT examinations receive no consistent education on what doses are excessive, how they can recognize when the doses are too high. The U.S. Congress had a second hearing focused on radiation safety to discuss the CARE bill, a bill before the U.S. Congress that would help improve the standardization and teaching of technologists, and I think that would really go a long way to starting to begin to create the standards and understanding that would help this area. I want to show you one example I think is illustrative. This is a single patient who underwent CT scanning at 2 different times. On the left was one time, on the right was a second time. I included this in a piece I wrote in the New England Journal in 2010. This patient was seen at the same institution for the same reason, to follow a tiny pulmonary nodule. And you can see the nodule pretty well on both images. There's a large green arrow which helps, but I would argue you can't see a difference between them. On the left is a low-dose CT scanning of 1.5 millisieverts. On the right is a traditional CT scanning, 15.9 millisieverts. And you can see there's difference in the abdomen. You know, one of the pictures is much grainier. But I would emphasize that this patient shouldn't have even had the abdomen scan. This had a very targeted question, and we needed a targeted answer, and the low-dose study provides that. The higher-dose study provides much more radiation and no more information. At the time that I published this article, there was a very interesting article in one of the radiology journals that talked about the Fletcher Society guidelines for monitoring pulmonary nodules, and talked about the fact that most radiologists who do these type of scans don't know the dose they use. They're not familiar with the guidelines that suggest you should use the low-dose study. And I'm really hoping that's what we can do to improve, to start to do things in a standard way that minimizes and optimizes doses. A little bit that's complicated about the dose studies is there are constantly changing protocols for how to image patients. And there are a lot of real sophisticated techniques that have been developed that may or may not aid in diagnosis. They generate beautiful images, but there are very few evidence-based guidelines for how to use these. As an example, the radiation overdoses at Cedars-Sinai were from perfusion scans. And these are scans that lead to 10 times the radiation dose of a head CT when they're done correctly. When they're done incorrectly, it's 100-fold. And yet a lot of the patients who underwent these scans didn't need a perfusion scan. They would have done fine with a routine head CT. And practice variation in the use of these protocols reflects physician preferences, sometimes promotion of the capabilities by manufacturers, rather than evidence of improved clinical outcomes. And public health safety concerns have not been of utmost importance to those who have been tasked with buying equipment. And I think that needs to become very important to whoever's purchasing equipment to really consider the dose aspect. And I'm happy to report that that seems to be changing rapidly. I mentioned that Dr. Miglioretti is going to speak in greater about the impact of reducing the highest doses in children as part of our HMO collaboration. But I just want to highlight in one slide why this is so important. In our study of HMO patients, looking at children up to age 15, we had just shy of 5 million patient years of follow-up. We looked very carefully at the organ doses that these patients received based on their size and age and so forth. We found that over 10% of patients in this cohort received as part of a single CT scan doses that Dr. Pierce tells us triples the risk of cancer. We estimate in this cohort using Bear7 methodology that we could expect just shy of 10,000 cancers in the U.S. from imaging children. And yet if we could reduce the highest doses, take the highest quartile of dose, the highest 25%, and these doses are truly outside of what we need, and reduce it to the median, we could lower the risk of cancer by 44%. So getting rid of those high doses could truly have a very large impact on the harm of our CT scanning. So in terms of how CT scanning can be reduced and safety improved, the manufacturers are developing many software and hardware solutions that I'm very excited you'll have an opportunity to see at the meeting. I hope you choose to go to spend some time in their rooms because many of these solutions are fantastic. And yet this is not going to happen overnight. It's going to take a decade or longer to replace the current scanners. And thus I think we can't leave it to the manufacturers alone to solve the problem. We need some more concrete steps that you can take immediately. Organizations such as the Joint Commission are making recommendations, but these are not yet final, and as currently there are relatively few specifics. Government regulation is starting to be implemented. In California, we have SB 1237 that requires reporting of radiation information in the medical record, and many other states are following suits. For example, in January, the Connecticut legislature discussed legislation that had many similar requirements as the California legislation. All of these things you can learn more about at the meeting. We have several legislators who will tell you about things that are going on in the U.S. Congress, in the Center for Medicaid and Medicaid Services, the Joint Commission, the FDA. But I think we need to make changes immediately at our practice locations. And I think what we need to do is we need to collect the dose information that you're using. I've shared some of the doses that we have. I'm going to share some more over the next day. But you need to start to look at your doses. You need to compare the doses you're using to benchmarks. And you need to educate physicians, staff, as well as patients into these areas. I think it's incumbent on us who use medical radiation to do so safely. I'm going to tell you in a different talk a little bit more about the UC dose collaboration, which I think is very interesting. It's a collaboration across the 5 University of California medical centers that's focused on dose optimization and standardization. It was funded by the University of California Office of the President, their Center for Healthcare Quality and Innovation, and I'm grateful to them for allowing us to collaborate and for them to support the meeting as they've done. The funding has allowed us to begin our collaboration across our group, and we're hoping that we really can provide a lot of guidance nationally in the area of radiation safety. In terms of our specific areas, first is to just begin speaking as a collaborative group, radiologists, physicists, and technologists. And I can't emphasize enough how incredibly helpful this has been to us. We have a lot of experts within the UC system, but we haven't really spoken together. And it's been really exciting to start to work together. I encourage you to do the same kind of collaboration. We're also planning to standardize doses. That means to optimize doses and minimize dose. We're planning to benchmark doses. We're going to create standard protocols that are going to make widely available. We're planning to educate staff, and that's really what this meeting has grown out of. And then we've developed consensus about ideal ways to respond to SB 1237, and we have a newsletter that you can download from our website that will give you details about how we believe is the most responsible way to respond. So what should you do? First, you need to start assessing the doses you use for routine patients. To do this, you can upload your actual dose information for no charge as part of participating in this meeting, and you can immediately compare your doses on the machines that you have and to the patients that you see to your peers using a National Quality Forum adopted measure. If you choose to delve into your doses in a greater degree, you can complete a quality improvement project, get maintenance of certification credit as part of the American Board of Radiology approved projects. You can look at your dose. We will help you develop a project to improve what you're doing, and then you can look at your dose again and you get credit for doing so. Someone at your institution needs to take the lead on looking at the doses you use, overseeing protocols, standardizing protocols, and looking at the dose data. And that person can be an administrator, a technologist, a physicist, a physician in radiology, a physician outside radiology. But someone needs to take the lead to acknowledge that this is a problem for most facilities, and you want to know where you stand. And we have a lot of talks at this meeting that really will help you learn how other facilities have successfully tackled this issue and the challenges that they face to do so. And as I mentioned, a lot of vendors have products both in creating lower dose exams, but also to help you monitor the doses you use and the protocols you use. We have a dose challenge at this meeting that I hope you will choose to look at that will really help you understand those different products and what they offer. And I think the first step is to look at how you're doing, and I think that will go a long way towards the next steps of improving how you're doing and reducing variability. I gave this talk the title of A Hidden Epidemic. I think clearly it's been hidden. People have not known about this topic until very recently. Patients have not known, radiologists have not known, ordering physicians have not known very much about the radiation doses we use. And I'm happy that this is improving, but we have a lot more work to do in this area. An epidemic is defined as a rapid rise in the number of people who are exposed, and clearly this is the case. But I'm hoping that meetings like this will increase awareness of this topic, and there's growing consensus that there really is a need to improve the safety of medical imaging, and I think we have a lot of strategies for doing so. Thank you so much for attending and for your attention, and I'm happy to take some questions.